Good morning, everybody. Can I ask people at the back, please take your seats, and we're going to go live stream straight away. Good morning, everybody. That's me in the corner here, as the REM sound goes. Yeah. People normally say, "Can you hear me?" But can you see me? It's one of the disadvantages of being 5'4". I'm over here in the corner. Okay, good morning, everybody. Slightly different format for today, and welcome back to day 2 of our assembly meeting, third assembly meeting this weekend. Slightly different format for today. Thankfully, only one PowerPoint presentation, but it's a really good PowerPoint presentation from Jo-Hanna. But a slightly different format today, and after the first presentation, I'll be handing across to Derval MacDonald, who you'll know from previous assembly meetings, a broadcaster and journalist, who's going to facilitate a discussion with our panellists, which Derval will introduce at that time. First of all, I want to introduce again, who you'll be familiar with from a previous assembly, is Professor Jo-Hanna Ivers from Trinity College Dublin, a professor from Trinity College Dublin, associate professor in addiction, as well as many other talents as well. Derval sent me a special request late last night and this morning that she wants to have she wants to have one extra minute for her presentation this morning, so she's promised me it's going to be 16 minutes instead of 15. So I'm going to hand across, thankfully, now to Jo-Hanna and welcome everybody again this morning. Thank you.
Technical difficulty.
Go. Okay, good morning, everybody. Over to Jo-Hanna. Thank you.
Hi, everyone. So as Paul says, I'm Jo-Hanna Ivers. I am from the discipline of Public Health and Primary Care in the School of Medicine in Trinity. And the last time I spoke to you about drug use at a population level, focusing on harms all the way up to addiction and dependency. And today I want to talk to you about something that's really close to my heart. It's building systemic capital to advance addiction recovery in Ireland. And in doing that, I'm going to tell you what I mean by, or what we mean as a field by recovery, where we are with that at the moment in terms of its strategic response, how we got there, and where we need to go to do better, because this is a space that we really need to do better in. So to acknowledge the fact from the outset that we have a really strong recovery community in Ireland, a really strong cohort of people, recovery is possible and it is visible. It tends to be visible at different times of the year, but we have a really strong cohort of people doing excellent work, and we really need to support them to do a lot more. In terms of what do I mean when I'm talking about recovery, recovery is life after drug use. So when a person resolves their drug use, whether that's to stabilise, reduce or abstain, and recovery is a self-defined term, so people decide themselves when they're in recovery. But recovery is the stuff that happens beyond the treatment effect or beyond the work that the person has done on themselves, and how we quantify and measure that, because people think it's very woolly and we don't know what we're talking about, but there's actually quite a staunch hard science behind it. And we will refer to a term, and I know some of the panellists will, talking about recovery capital. And they are the factors that people have in their lives that help them sustain their recovery. And some people touched on them yesterday. That is having access to education, training, housing, employment, somewhere nice to live, somewhere nice to be, and engagement with your community, amongst other things. But they're the quantifiable things that we do know what we're talking about, and we can measure, and we will know what it looks like when we get success. So in terms of a strategic response to drugs, we are still relatively new in Ireland. Our strategic response only came in the 80s. And again, not to advocate for American strategic responses, but they would have had a strategic response in the 60s. And similarly, our nearest neighbours in the UK would have been developing strategic responses to drugs in the 70s. Ours was born out of the opioid epidemic, which we all know about, which was predominantly in both north and south inner cities. And the purpose of that was to respond to the outbreak and emergency spread of HIV and hepatitis and contain that. And in containing that, then reduce the crime rates. So in terms of successes, that was really successful because in some cases we've eradicated hepatitis and HIV. The crime rates were stabilised for a period. So as a strategy, it was effective. We tended not to really go back to evidence, and we repeated that, as you can see, all the way up until the latest strategy, which is reducing harm, supporting recovery. Now, on first reflection, it looks like it is a partnership between harm reduction and recovery. Unfortunately, it isn't. It does have lots of successes, and I'll talk about them in a second, but I think the biggest win that we have in the current strategic response is that it's action-focused. So it's got 50 actions. Most of them relate to harm reduction. Listen, harm reduction is the beginning of a journey for people in recovery. I'm not advocating, you've heard this term, I'm sure, lots of times around the continuum. The continuum absolutely begins and does lots of great stuff in the middle with harm reduction, but at the end of that, we should be aspiring for recovery. So, listen, it's been positive on many levels, but as I say, it's action-focused. It's got an office that's responsible for it. It's got monies behind it, and it's got a timeline. And anybody that knows anything about implementation knows that they're the bread and butter of implementation. You need a person who's, the buck stops with them. You need the money, and you need it to be time-bound. So all is not lost. What I would say is we've got a good example of how we do harm reduction really well. Now we need to map on how we do recovery really well with that. So, as I say, lots of successes with harm reduction. We talked about successes yesterday in terms of health diversion, excellent. Drug checking, excellent for the population who use drugs, and we need to keep safe. And just to say, if you look at my profile, they are projects that I'm aligned with, so I'm absolutely not opposing harm reduction in any way, so don't take that from today. What we have done is we've streamlined case management and common assessment. That might seem like a small thing, but what it means is every service user now gets a quality and a standard around assessment in Ireland. That wasn't always the case, and it took 2 decades to nearly get there. We have a shared language, and we've reframed it as a health issue, and addiction is absolutely a health issue. And so is recovery. But the trouble with recovery is when we're talking about housing, education, employment, training, suddenly we're going outside of the domain of health. So again, you can see where the lines are blurred, and I'm going to talk about how that plays out in service when we're trying to deliver strategically on things that we need, but isn't always our business in health. And it is aligned with the National Healthy Ireland framework, which again, I'll talk about why that's a positive. So just to give you a very brief view of what it looks like when someone shows up to treatment and tries to get recovery. So a bunch of people show up to get to treatment, and some of them will lapse and relapse. Fewer of those progress to treatment. Fewer of those attain recovery. So in other words, resolve that drug or alcohol problem, and or reduce or abstain or stabilise. And very few people go on to sustain recovery. And what I mean by that is if I come back in, someone tells me today they've resolved it, if I come back in 6 months, 12 months, 24 months, 5 years, would that recovery still be sustained? And the reason why that's important is because if somebody makes it to 5 years in recovery, we know this from John Kelly's work in Harvard Medical School. If someone makes it to 5 years in recovery without any lapses or relapses, they only are at risk for relapsing in the same way as someone who was never taken or has never entered recovery. So that becomes a really important number. So this group, as I say, are in the minority, the sustained recovery group. So when we talk about the people, what's different about the ones who show up to treatment and don't manage to sustain their recovery? So what's different about them is we know they're more likely to have experienced high rates of trauma. They're more likely to be a parent. They're more likely to have a co-occurring mental health issue, and I would say physical health issue. More likely to be experiencing homelessness at the point of treatment and certainly at the point of leaving treatment. More likely to be an early school leaver and more likely to have experienced high rates of unemployment, if not whole life unemployment. So what happens and how this plays out at treatment is that you've got to fight for recovery capital to be developed, a fight from the service user and a fight from the frontline worker. You've got a frontline worker trying to find somebody a house in the middle of a housing crisis while they might be in detox. You've got a frontline worker trying to assist in helping someone get their physical and mental health issues sorted out while they're in treatment. You've got a frontline worker trying to get someone into a HEI, higher education institution, when our numbers have never been higher. You've got them trying to negotiate an employment market when we've never called for more skilled people in Ireland. You've got them trying to resolve often a lifetime of social services issues and a very complex relationship with the justice system, where people are being punished for using drugs, and that punishment goes on and follows them through their recovery. So that's the kind of pressure we have our workforce under at the moment. You've got them trying to deliver on a health-led approach that actually is using the frontline workers, pitting the service users against us, and using the health budget to actually address what should be a cross-sectoral response. So what do we need to do, or where, ultimately we need to disrupt this very poor system that we're in. And listen, we seen the showcase yesterday. There are amazing things going on, but the pressure that's on the frontline worker to do everything it's impossible and it's unsustainable. So what do we need to do to ensure that everybody that shows up to treatment at least has the potential to sustain their recovery? Well, surprise, surprise, Zilla, we need to harness this recovery capital at a systemic level. We need our key partners across housing, health, education, employment, social services and justice. And it will go beyond this. We need planning and other environmental, but these are our key partners. These are what we know. If you were to pick up the literature tomorrow, this is what you would find scientifically that we know when a person has these partners truly providing resource. This is where we know that people sustain their recovery. So I suppose it's a much bigger issue than just giving someone a place at treatment or giving someone a bed in detox, because effectively that's what we're doing at the moment. We're giving people a place in treatment with sometimes amazing key workers, case management, first-line workers who are filling that gap and doing the impossible. And what that means is if we keep going the way we go, we're going to always have this guy, the guy that shows up with the capital, or at least some of it, and then you can top it up. He's going to be the guy or the girl or the they that is going to sustain their recovery. So when we look at this through that lens of the difference between equity and equality, so not just giving someone a bed, but actually looking at their needs, how do we achieve health equity? Well, we achieve health equity by addressing the underlying issues that prevent people from being healthy. So we know from health policy, good health policy, that where we work, where we live, and where we play determines our health. And it certainly determines our recovery. So understanding that while not all government agencies have a responsibility to health or have a remit in health, they do make policies and protocols and build stuff and put infrastructure in that has a direct effect on people's health. And that has a direct effect, obviously, for our community in terms of recovery. So very simply, and this is a much bigger issue that deserves a lot more time, but what we're talking about is the social determinants of health, and it's exactly what I said a moment ago. Where we live, where we play, and where we work will determine our health. The good thing is, I always come with the evidence. We've got a really strong evidence base around this. This is not a new idea by any measure. this is something that was born out of the WHO, but we have lots of jurisdictions, lots of evidence showing that when we have health in all policy, health improvements are clear. So what the evidence base, and I apologise, this is my only text-heavy slide and I won't read it, but it's for your information and for the Assembly beyond this. What we know in terms of key messages is when we put health in all policies, it improves population health outcomes beyond. It enhances a coherence in policy that is sustainable. But ultimately, even if you don't care about health and even if you don't care about recovery, economically this makes sense because in the long run, you will get way more bang for your buck if you invest in health in all policy. So ultimately, what we're doing is we're taking this as a framework and we're saying, how do we achieve equity in recovery? Well, recovery equity, again, will be achieved by addressing the underlying issues that prevent people from sustaining their recovery. So where people work, where they play, and where they live is very important. And understanding that while our cross-sectoral partners do not have a remit in health, their policies are directly affecting people who are trying to navigate harm reduction, trying to stabilise their drug use, and ultimately trying to get into recovery. So again, and this is not an exhaustive list, but I'm tying this back to the evidence. When we look at people who succeed in recovery, what we know is they have housing, stable housing that is supportive, and sometimes that is recovery housing, and that's a much deeper issue that I'm happy to take up with people. Again, we've got lots of evidence base there. They have access to education if they choose to, and if that's the appetite that they have, or indeed employment or education or both, that they have support with social services, support with justice, and that will lead to a quality of life that we all aspire to and want to enjoy. And ultimately, by fixing this, we're talking about prevention. And one of the bugbears I have is that people always think that prevention is about taking a program and going into a school and telling kids not to take drugs. And that is part of prevention. But ultimately, prevention is not different to recovery. Prevention is about creating opportunity, creating pathways so that people don't go down a road that they might find themselves on that's messed up their lives. So we need to start to see prevention in that way. And again, I would say recovery and prevention in all policies. I do know I'm at this Assembly and the next one's going to address that. But so what would that look like and what do we need for that to happen? Well, we need political will. If anything, take from this today that we have people on the ground that are passionate about making a difference. And we have people that go to work every day trying to get people over the line, either to harm reduction or recovery. So we're not lacking the grassroots movement. We need it from the top, and we need mandated support where people row in from other sectors and, give resource, give time, and come together. And it is a speculate to accumulate, because what you give out, you will get back. So yes, it will immediately be about budgets, but ultimately in this time of sustainability, that is the kind of long game. And the evidence is there. It's not me just piping this up. We need stakeholder engagement. We should never do anything without the people it affects. We need evaluation frameworks, and that's because we need to know what we're measuring, how we know it's successful, and how long it's going to take us. And ultimately, those evaluation frameworks will help us with the context-specific elements too. So it's going to be different in housing than it is in education. And I suppose that's it. That's, for me, what we need to do to advance addiction recovery. So thank you.
Jo-Hanna. Thank you very much.